we can demo and practice once we kind of go through it the first time. Okay. So some of you I know were here last quarter for our inpatients. So it's going to be very similar to that for those of you that have done this before in terms of the expectations of the physical therapy students. You're going to be in bed to start. The goal of the students is to get you out of bed to the wheelchair, and then they're going to switch places, and the other student's going to get you from the wheelchair to the bed. Last time it was a cardiac case, this time it's a neurologic case. So, and really the focus for this time is for them to navigate someone who has difficulty communicating and difficulty moving. So the main focus are going to be those areas. So you are going to be an inpatient, so we're asking you, you're going to be in a gown, so either a sports bra, tank top, and shorts are appropriate. So we'll have a hospital gown over top of you for the day. You will have the IV. We'll use the sleeve like they typically do to just have the IV in the one arm, and then we'll have a strap that goes around your leg for the catheter. And those should be really the only two lines that you really need to worry about it. You will be on a stroke unit in the acute care setting. You'll have had a stroke the day before. For those of you that like the medical information, it is all there, but since you all have communication issues, you won't actually have to communicate it to the students, so that gives you a lot less to have to memorize. But it's going to have been a left ischemic stroke, so your right side of your body is going to be affected, and your speech is affected. The information here the students will have, again, because you can't actually verbally answer these questions, it's just giving you a little bit of the backstory, that you started having trouble speaking, your vision seemed off, and suddenly you felt off balance. Your spouse or significant other called an ambulance. You have a past medical history of hypertension, hyperlipidemia, and type 2 diabetes. Again, all the students will have this in the medical record.
When we had, we fell off balance, did we have a fall?
No, so you didn't fall and hit your head or anything of that nature.
Okay. Thank you.
Yep. So you are able to tell the students like a first name. But again, like you can't answer long questions. So when they ask you for your name, but you're going to be slow. So what you're going to, so in responding to them, you will respond with a first name, but it'll be extremely delayed and slow in getting it out. So again, thinking your speech is affected, really hard for you. You can understand, but you're having a hard time getting those words out. So if I said my name is Megan, I might pause, what's your name? Maybe trying to think about it, and then Megan.
Oh. No slurring, just slow in response.
Correct. So you
okay.
Can, yeah. I'm not going to worry too much about the specifics about the slurring. You'll see as we go forward, anything more complicated, you're going to gesture or maybe, or a yes, no.
Right.
But no, you're not going to actually be able to speak in full sentences.
Okay.
You know that you are in a hospital, but you don't know the name. So again, if they ask where you are, again, you can say hospital. And if they ask you to clarify what hospital, you can just kind of shake your head. If they you're not going to be able to answer a day of the week or time. If they start saying, is it, and you have to answer yes, no, you can just be a little bit confused at that point. So again, you understand the questions being asked of you, but you have difficulty getting the words out. So you can imagine if you can't do that, you're really frustrated. Because you can hear them, you understand them, but you can't always make your the correct answer or your needs or wants known. You can for any other questions you can gesture. So if someone said, does something hurt, and you had to point to somewhere, you can gesture. We're gesturing with the left hand because the right hand is impaired. And you can shake your head yes or no. If they ask you for consent to participate in physical therapy, we do want you to shake your head yes so that we don't stop them from continuing on. Now again, these questions that we're going to go over, you're just answering yes or no to, so you want to have this picture in your head, but you don't have to have an elaborate story that you need to tell, because you're only going to be able to express things in that very simple manners. So any home environment that you're familiar with, whether it's an apartment or a house. So do you live in an apartment? You can shake yes, or you can shake no if they ask. If they ask where do you live, you can just get very frustrated in the answer. You can try to say something, but nothing comes out. Or if they say where, or the best you can come up with is yes. Where do you live? Yes, which wouldn't answer the question where do you live. So they might have to switch to a yes/no question. If your residence has any sort of, if they ask about stairs and you say yes, you can, again, with your left hand, give, finger number of, 5 steps, or if you were going to say 10 steps, you could, gesture something with your hand, but you're going to, again, only gestures with your hand, not actually verbally answering them. So they're going to have to pay attention to that. If you live in an apartment or a house with no steps, then you can just shake your head no, and you don't have to answer that. Same thing if they ask location of the bedroom, location of the bathroom. So again, just picturing where, something you would naturally be able to answer, so you don't, again, something you're familiar with, so that you'll be able to not quickly, but you'll be able to answer it without having to be surprised about that they're answering that. If they ask you about, your prior level of function, you can't answer. So, like, you're not going to be able to tell them that you walked around by yourself, you got up and down stairs, none of that will be there. They do have information in the medical chart, but that's what we're going to have to rely on for their answers. Again, all of those medications you're not going to be able to answer anyway, but they have it, so you don't need to memorize any of them. Again, for those of you, for your character, would like to know all the medications, they're all listed there. Underneath of each of the medication, it states what they're for. So if anyone has questions, I'm happy to answer that. But again, those are things you're not going to have to answer. Current medications, again, most of us when we're in the hospital, unless we're really with it and asking 1,000 questions, probably don't know all the medications that they have in the chart anyway. But those are the medication lists that the student will get. So in terms of posture, you have hemiplegia or hemiparesis, which is that weakness on your right side. So after the stroke on your left, your arm and leg do not, don't move very well. They're very difficult to move. Same thing if you're sitting. I'm going to move our questions here a little bit. So, if you're sitting, again, this right side, yes, perfect over there, kind of drooping over, you don't have much balance on that right side, you're going to shift your kind of weight over this way. If they were to shift you over this way, you're going to kind of be a little off balance to that right side. So not much control. Now you're not falling over readily every 2 seconds, but you definitely are going to, if they don't pay attention to you, we'll talk a little bit about that. But really, this is, if you're going to do anything, support yourself, it's going to be that left side of your body you're supporting yourself with, both leg and arm. Again, kind of thinking just generalized weakness, so you're not going to be sitting up nice and tall, you're just kind of, again, kind of slouched, shifted over to that left side, that right arm, right leg, not doing a whole lot of anything. And in terms of any lines and tubes and hookups, we talked about that a little bit. You're going to have an IV on your left arm. We will have a pulse ox that they can remove, so just a finger clip that they can remove, and then we'll have that catheter that'll be strapped to your leg. Those are the vital signs. Not really anything you need to be worried about. They'll worry about them on the monitors. But they may ask you your level of pain. They may also... and so they may ask you out of a number scale, or they may have a visual scale. So the picture on there is just of a common visual scale that they might use. Again, you can gesture with numbers on your hand. So if you were, you could put up 2 fingers. You could point to the smiley face that is kind of just below the 0 where it has a 1 or a 2. Or if they don't show you anything, you can kind of, do this with your hand. So kind of like, do you have any pain? And you would kind of do almost like a so-so.
I mean, where is our pain?
So there's not anywhere, in particular at this point.
Okay.
And so we'll talk a little bit about it when you're moving, but just kind of, it's more that uncomfortability of like you can't move. So sometimes people are going to misinterpret pain as opposed to discomfort as to I can't move something. So very generalized, not specifically going to point anywhere. But great question. In terms of sensation, they may, hopefully, if they know that you had a stroke, they're gonna know that your neurologic system is impaired, and so they may decide to test sensation. Usually they do that just with a light touch of their finger, so they may just run their finger down each side. You're not, again, if they're going to do it and they want you to lift your arm, you can lift your left arm, your left leg. If they ask you to lift your right arm at all, you're just going to keep it where it is in bed, or if you're sitting up when they do it, just keep it kind of rest it where it's at. They shouldn't ask you, but I'm just in case they do, but they may touch both sides. It's going to be decreased in the right side. So a little harder, you're not going to necessarily be able to verbally say something, but hopefully if they give you if they realize you're having communication issues, they may say, when you feel this, can you give me a thumbs up? Or another gesture. If you feel this, can you can you tell me? You can't tell them, but you can gesture. And you can spontaneously give a thumbs up, tell me when you feel this. And instead of speaking, you give a thumbs up. So again, you can spontaneously give them the thumbs up, and we want them to be looking for that thumbs up as opposed to like ignoring you. So again, if you are laying down in the bed and you're giving a thumbs up, but they're only looking at the right arm, they might not see that thumbs up. So part of our goal is that they're going to be paying attention so that you are communicating with them, but not verbally like they'd be expecting. So anything on the left side, you're going to immediately respond to. You feel this as soon as you actually feel it. If you don't feel it, don't need to respond, because sometimes we will airbrush or pretend we brush somewhere to see if the person's accurate. So once you feel them touch, no delay. If they touch on the right side, you are going to respond, but it's going to be a slower. So you'll feel it, count 1 or 2 in your head, and then you can give the thumbs up. We have a 3-second delay there. Again, I'm less concerned about the exact accuracy. Just make sure it's slower than the left side. So you don't have any specific range of motion restrictions. Anybody have any range of motion restrictions that you want to ask or are concerned about? Meaning that, if they move your arm, if they move your leg, they can move it through the full range.
But we do for our right side.
Actively, yes, but if they move it for you, they can move it. So,
okay.
So Heather with a PT, and she came over and was, you can just do the right side.
Mm-hmm.
So left side, she'd be able to take it, I'd also be able to move it, but on my right side, I'm not going to be able to move it, but if she went to go move it.
So the students might say, can you move your leg for me?
And, again, I might try, but I'm not going to.
Wiggle your toes, I might ask.
So again, you can try, you might get a little.
I'm going to move your ankle. You let me know if it hurts.
So I'm going to let her move my ankle.
So then I would move your ankle. I'm going to move your knee. You let me know if it hurts.
And so I'm not giving her,
She's not helping me.
So it's like kind of dead weight.
Yeah. All right, I'm going to move your hip. You let me know if that hurts at all.
And again, dead weight. And
So
just
I'm
let
doing
them.
all the moving.
But if she were to do this side, again, or actively ask me to move, what we don't want is you to stop them from moving your limb. So that, there's no, and again, this would be almost to your question, did you fall? Did you break anything? Is there something, did you have any pathology underlying before the stroke? And so, but actively, absolutely. If they ask you to move it, you can't. Passively, they can move it. In terms of strength, again, anything on the left side, you're going to be able to move, resist as best you can, whatever your natural strength is. So if they come over and they're pushing down on you on that left side, you're going to give full resistance back. So if she's...
So I might say to her, can you wiggle your fingers for me? Can you move your wrist up and down? Can you bend your elbow up and down? You go up and overhead, so she can do all of that. And then I might test. I'm going to have you hold your shoulder right there. I'm going to press down on you. Don't let me move you. She's showing me all her strength. Same thing. You might say, bring your wrist up. I'm going to push down. Let me see your hand. I'm going to see your elbow. Give me a bend in your elbow. I'm going to try to straighten you. Don't let me. Just some overpressure. And then on the right side, if I said the same thing, can you wiggle your fingers for me? Can you lift your wrist up and down? I would expect her to do that. Can you bend your elbow up and down?
So you can move the arm, just
Can you see? Sorry, I'm blocking your ear. You let me know. Can you move? Okay. And same idea. Can you move your arm up?
so again, you're going to be able to lift it, but not all the way. So if I'm lifting it
I'm going to
up
help you, and then I might move her shoulder.
all the way, so as long as she's doing it.
Same idea. I might move her.
I read somewhere that in here that we can't move our right fingers or wrists at all.
At all is fine. Your hand is more involved than your shoulder, and so you don't have to move the wrists or fingers at all, or very, very little. Like effort, but sometimes it's hard to like think about contracting the muscle and then not moving them enough. So if it's easiest, hand and wrist, nothing is perfectly fine. They're not getting graded on like a number that they have to do. So I'm less worried about the specifics, other than it is significantly weaker than this side. You shouldn't be able to do much. Again, you can kind of lift the arm, but, you know, if this is 90, you don't get up to 90.
Can we move our shoulders?
So again, you can, same thing, you can, but just, again, this is going to come up really easy. If you lift this one and they go to push down, you let it drop down immediately. The further away from your body, from your shoulders, is going to be more impaired. So less at your fingers, less at your wrist. A little bit more at the shoulder is okay, but again, no resistance anywhere in that right upper extremity.
One of the things I might ask is about gripping. Can you squeeze my fingers? So you don't want to be able to squeeze on that right side. You're not going to have that skill.
Right leg, same thing. You can lift it up against gravity, but if they start to push on you at all, so again, you can lift up here, and again, slow and going, but as soon as they were to touch you, just drop it down. Or
the right side?
On the right side, you can't do it. On the left, you're fine.
So she could come here and I'm going to push on your knee. Don't let me bend you. Don't let me bend you. She can hold. I'm giving all the pressure that I can when I come to this side. So I just, same idea. I might lift it up and say, okay, I'm going to hold it, and I would even think it would drop.
And then I'm just going to let it.
There's no resistance. She can't.
So I might be able to kick up, but it's just going to flop right down.
Same thing here. I would expect bring your knee up for me. I'm going to press on your knee, gently move you. Be strong. I'm going to bring this. I would expect she probably couldn't even lift it up that much.
Yeah.
So the students are going to do the same thing. And then if I resist it, she just has no strength there. A little bit of movement.
So your leg is going to move a little better than your arm. So you're moving it a little bit against gravity, but absolutely no resistance. The arm, again, hands, wrists, going to be the most involved. You're not going to be able to move it really against gravity except a little bit, so we shouldn't expect them to actually test it on your arm. When you lift and you can only get to here, there's nothing to test because we need you to get up before we test it. If they were to touch it, again, you're just going to let it drop because you can't even get it all the way up. Leg, you are going to be able to extend out, but absolutely no resistance. We do want them to stand you, so we want the leg to move a little bit. Because if it doesn't move at all, then they might be hesitant to stand you and get you in the wheelchair. So that's why the leg does have to move, just not just not against any resistance.
Does that make sense? We're trying to read faces, read your minds.
So when they get us up, what do we do with our right leg since we do have one? So can we drag it? Is there what takes us to the bed?
So we're going to go over that next.
Okay.
So you're perfect, great question.
Okay.
So we're going to start with in bed, right? So because you're going to be laying in bed, and then anything they want you to do in bed, you can move this leg this way. You can use it to try to push you up in bed, but do not use your right arm or right leg to assist you. So if they want you to roll over, you can use your head, but you're not really using that arm to reach. You might turn, that leg, but you can't, anything you can do with the left hand only. So if they had a bed rail up here, you could pull over. But, so they may say, can you reach for this bed rail? Now you're going to lay on your arm and get it stuck. But if they asked you, could you reach over here for the bed rail? Yes, you could do that, but you're going to just flop right onto that.
Why can't I lock that?
Thanks a lot.
And the mattress might be in the way a little bit.
Yeah, it is, that's exactly what it is.
Oh, thank you.
And they may not, again, they may just ask you to start to demonstrate while I sit there. If there's nothing for you to grab, and you can think about not being able to use that side, you're really going to have a hard time going over by yourself. But if you have something to grab onto, but now your arm and leg are stuck. So again, in bed, go ahead and use this side to help any task they ask you to do. Just don't move the right arm and leg. In terms of then lying down to sitting up, they may take you one direction or the other. Obviously, if they roll you to the right, you can't help at all pushing up because your arm and leg are underneath of you. If they roll you to the left, now this arm is under you, so you might be able to help, but remember this is just falling over. So you could push up here, but you're going to get stuck at some point. You're not going to really be able to get all the way up. So they're going to have to help you. Make it hard for them to help you, meaning like don't just, when they start to help, don't just sit up. Think about like the muscles in my trunk also aren't working on that side. In order for me to sit up, I'm contracting these muscles to sit up. So I can use this arm to, again, kind of push up, but I can't do it by myself. So they're going to have to put their hands on me, and you should feel them helping you. When you feel that amount of support, go ahead and let them pull you up.
Can I take a half a step back?
Absolutely.
Remember in the beginning when you sat up, you were balancing on your left-hand side, and you could fall to the right? If you fall to the right, then you're going to have to do your whole body to get you back up?
Oh, so if I fell over like this?
Yeah.
Yeah, it'd be pretty much what we would call max assist. Like, you're not going to be able to help them here.
Okay.
If they gave you something to grab onto, which, again, there's nothing here.
Okay.
We don't have anything intentionally for you to grab onto. So yes, if you fall over this way, you're going to stay there until they help you up.
Okay, thanks.
There are two of them. You would expect if they had, if they were reading this case, what I anticipate most of them doing is over helping you, over guarding you, not really letting you do much anyway. But again, if they did walk away and neither of them were paying attention, you would just flop and stay there. We don't want you falling off the bed, so please flop onto the bed if you flop. We don't want any injuries or anyone falling.
Watch your head.
Yeah, watch your head, exactly. So if you have to flop yourself a little bit away from whatever's there. But good question. All right. So again, this is a lot of balance. So you don't want to be able to sit up here and just kind of lean here indefinitely. So no more than like 5 seconds if they take their hands off you. If you feel that they are supporting you in any way, shape, or form, you can kind of lean that way and then they'll instinctively, and these students have done enough competencies, I do expect all of them that if their hands are on you and they feel you lean, they're going to correct you. But if they, again, take their hands off of you or are testing your balance to see how long, you're going to fall right over to the side right away. You can't sit up unless, now you can stay here, this is okay, but you can see I'm not upright. So I can lean on this arm, it's strong enough, but I'm not, so on my arm, or even on the arm here is fine, but I cannot stay upright in this position. I just keep falling over this way and having to try to use my arm to try to push up. This side's not really helping.
You're going to have an IV in that arm.
You're probably, most people aren't going to want to do a whole lot, so once you're over, let them help you back up. Again, now sometimes based on where they position me, if I'm here, I'm sinking to this side naturally. If for some reason they had you positioned and I'm sinking naturally to this side, go with what gravity is taking you. If I was naturally sitting here, I'm going to fall to this side because they put me in a position that gravity's just taking me down, so I am going to fall over this way. And we'll have you each try on the bed. You can see often when we put the bed up, it gets that like kind of natural indent, and you'll feel yourself, you don't even have to think about it, you'll feel yourself either go one side or the other. So just go with the equipment and let it take you whichever direction the equipment is naturally taking you. All right, and then for standing, again, we're going to have the, let's put the wheelchair over here so that they can what we're doing. I'll just roll over. So by this time, we would expect that, we would expect that they know you have significant weakness. They are not going to let you just get up and stand. You can't sit fully by yourself. So we would expect them to help you stand. I suspect what they're going to try to do is they're going to take this armrest off and they're going to try to keep you as low as humanly possible and do what we call a squat pivot, where they're going to, you want to do it?
Yeah.
Okay. So hopefully they take this off.
I love moving you around the planet. It's so fun.
And out of your way. Otherwise, they're just going to bump you into the armrest. So do you want to get? No. So what they'll probably do is kind of flex you over and keep you real low and not ask you to stand. That is the more likely transfer they'll pick. So we'll show that one first. And so they're just going to swing you over. That is more likely, and so, again, if you're thinking about it, it may happen so fast, but if you're thinking about it, all the weight should be on the left, not the right. If they do attempt to stand you, what will happen is as they stand you, if they're not, well, we're not going to have you flip-flop any to begin with.
Okay.
Heather's going to do it wrong to start with. She's just standing in front of me, and she brings me up. I'm going to let this knee on the right buckle. Now, what she naturally did, because she does this all the time, is she stood in front of me and blocked my knee. So if you want to do that, then.
Yep.
So again, if they're anticipating it, they may block the knee. So as she stands me, when it's there, and my knee goes, I'm going to still let it go, but her leg is going to stop it. And you'll feel that. So just, if they stand you up, they may not, but if they stand you up, that knee is going to buckle. And if they're doing it right, you're going to feel that you can't buckle your knee. Those would be the two types of transfers that they would be able to do. Again, we suspect they're probably going to take the safe route. We'll talk to them afterwards about if the goal is only getting the share, but if you need to assess the patient, we would really want them to stand to see how much can that person do first. And so if they do it, that's great, but I do think a lot of them are going to they're going to worry about safety and not as much challenging you. For those few students that are more confident and are really going to do that, they will stand and challenge you and make sure that you're safe by blocking your knee. So that would be great if they do it, as long as that knee can't give way. But again, yes.
The notes say that on day one we refused to get out of bed. How cooperative are we and how cranky are we?
You can be cranky. You can be very cranky, but you do.
But no acting needed.
What's that?
No acting
Perfect.
needed.
Yeah,
I pay myself.
I do a very good cranky patient burnout. So you can be very cranky, but do participate. So you're not going to refuse participation. It can be exasperation, are you willing to get out of bed? But not a no. So we do want them to coax you, etc.
We do consent to participating in physical therapy.
Correct. Yes. So in the beginning, you consent to physical therapy. Again, but as part of you may consent to physical therapy, but still, a lot of patients are like, yeah, I'm not getting out of bed, but I'll do whatever you want in my bed. So in this case, we do want you to be willing to get out of bed. You can, again, be frustrated by it, exasperated by it, but you will ultimately be willing to participate. Now, again, you can try, they may tell you to lean forward a little bit, you can kind of give that lean, but when it actually comes to pushing up and standing, they should be doing most of the work. So you can give a little effort on that left side, but it should be almost a deadlift for them. If they do it right, it doesn't really matter your size. If they get you to the edge and they get your body weight over here, they can transfer you over in this direction with very little. They don't need a lot of strength to do it. It's all about body mechanics. So if they're doing it correctly or not, we don't want you to help because we want them to practice that skill of getting you over. You'll notice that if you're sitting way back here, it's going to be hard for them to do it, which is why, they know that, which is why they need to get you all the way over to the edge and then spin you into the chair. Remember the whole time, the hardest part of this is that arm and leg on that right. Just kind of think about them like being kind of a limp noodle on that side, not using that arm or leg to really help you. I did give you some pictures on some way they would block. I don't expect them. The one where the person is knee to knee in front, which Heather had just demonstrated, is the more likely if they stand you. The other one would be on your side. They'd have to grab one of the chairs or a stool or something to do that. It is an unlikely technique they would use. You can stand and squat and do it. It's a higher level technique we would use in a rehab, not typically in an acute care setting. But I just put it there so you could know that there is some really farther stretched out technique they could use, but it would be highly improbable that they'll pick it this time through. So again, if you start getting this way, but they're not helping you all of a sudden, so they rock you forward, and then you get right here, and they're not helping you, just allow yourself to flop back down so that they give you more help. You should be able to feel that help as they stand and pivot you over. If you feel like they're just kind of hands are on you and you're doing all the work, just feel free to plop yourself back down onto the bed. Again, you can follow basic instructions. So as long as it's very straightforward and simple, but you can't verbally answer beyond pointing or yes, no. So if they ask you to lean, we would expect you to be able to follow and lean. But if they're asking you to answer in a sentence, that's where that frustration would increase. Or you gesture that, and it just doesn't make sense because it's not a yes, no, or simple response, or up, down, or a number. Anything that a simple gesture will allow you to answer, or yes, no. We hope by the time they're getting you up and into the wheelchair that they have figured out that that's your level of communication. While they have 10 minutes to get you into the chair and 10 minutes to get you back, it is going to be more difficult for the first person. So I would not be surprised that that first person goes over that 10 minutes. They did in our cardiac case, a couple of them. And we've already, if they're already mostly through the transfer, they know to keep going until they get the person there. But if you hear that 10-minute mark and you're being really cantankerous, you can lighten it up a little bit so they can sort of get you back in the chair so they can swap out. If you're still laying in the bed, we'll figure out, send somebody in to come and assist at that point in time. This is the first time we're going through this case, so we're trying to think of all the scenarios. After round one, we'll probably figure out where some of the students have a tendency to lean that we didn't anticipate, and we'll come back and fill in any necessary information, either in our pre-brief to the students or here. I did practice with several students who are a year ahead of this group, and it seemed to go well, but they're a year ahead, so they have more knowledge. So sometimes they guess, sometimes we can't guess what the actual students in the group will do, but we think we've gotten most of the scenarios that would come out.
This is our first stroke, obviously.
This is your first stroke, yes. Again, the information after that is just the detailed information we already talked about that was provided to the students. At the very end, we do have student 1 and student 2, so you know what's going to happen each part. Student 1 is supposed to get you from the bed into the wheelchair, so that's pretty much what we've gone through already. Then student 2 will swap out, and the person is going to come in at this point, and you're going to have been nicely seated in the wheelchair, and they are going to want to get you back into bed now. So you've been sitting up for a few minutes, for hypothetical minutes because of time. We're not actually having them leave and come back to get you out of the chair. We've asked them that once they swap out, pretend the patient is sitting there for maybe 15 minutes or so, and they're getting you back into bed. At this point, you are going to start to have a lot of pain in your right lower extremity. What we want them to try to rule out is where this pain is coming from. Could it possibly be a DVT? Because there's protocols they would need to follow if it was. And so what we want them to be able to react to is this high level of agitation and pain. So this is where vocalization, where you can be really uncomfortable, and if you're, if you can point, you can, try. Again, we don't want you to fall over. So if you're sitting here, it may not be exact. So it's not. But if you can get that left hand to get anywhere, and if they then start palpating anything in your path, is going to be really sore and tender and really increase your pain level. If they ask you, on a pain scale, again, you're going to go almost all the way to the top to that 8, 9 mark. If they show you something, if you're gesturing, or they give you a number as a 5, you can, up or up, but something that, just you're super uncomfortable and really, and really just don't want to move, especially if they go to stand you. So, again, you can start out like, ugh. And then if they're asking you to do more or they're ignoring you, that's when you want to become more agitated and more uncomfortable. Now, if they ignore all that and get you back in bed, that is perfectly fine. You will discuss it in debrief. But you're just going to be really uncomfortable and kind of yelling in pain if they go to weight bear you and transfer you back to the bed. Otherwise, what we would expect that they would call the nurse's station, we would, and then send someone in and stop the sim at that point. If they get you back in bed, that's fine too. That sim will be over once they get you back in bed. Again, we hope that they would follow up with the nurse or physician at that point. But your function, other than pain, your function is the same. You can't move the arm and leg any more than you did beforehand. Yes.
This is the first thrombosis we've had?
Correct. Yeah.
And do we know what it is, or all we know?
You don't. You just know you're in pain.
Okay.
You just know that right leg is suddenly in severe pain.
Are they going to ask anything about our spouse?
They may, and so yes, no questions in terms of do you live with someone? The answer is yes. So again, spouse, significant other, you can pick. We did say in the record that you had a spouse, so that took you there. If you have other family members, that's fine. But you do need to be living with a spouse of some sort, whether you're getting along well or not, we don't care. Someone is physically living in your house, and so if they do ask, again, that would be a yes question, and then no to anything that they ask that you didn't think applied to your scenario with living with your spouse.
Will they ask, have we ever had this pain before?
If they do, the answer is no.
So it happens just at that moment.
Correct. Well, once you're in the chair. Now you can start quietly grimacing once you're over here and they're swapping out people. So as they're changing people, you can just be really uncomfortable and taking some deep breaths. But as they progress, and certainly as they go to get you up, you want to make sure that it's evident that that leg really hurts at this point.
Quinta wants to do like the mock-up. Quinta wanted to do the mock-up with IVs and stuff.
Oh, sure. Okay.
I have a question.
Yes.
So, at any point, what if let's say, worst case scenario, you have a transition you have a student that's super nervous, and just
It's going to happen.
right,
Yeah.
and you have a transition that the SP doesn't feel safe with because it feels like maybe they're not blocking properly, or
Oh, we don't want you to fall. So if you feel like they are pushing you over, and I have been there when we've done gait training, where I literally can't move my leg because they're I just can't move. Their body is in my way. You put your feet down and do not fall over. We do not want you to actually fall over during any of this. Make sure you maintain your balance, and you don't let them, fall to the ground. Again, that's the same thing with balance, sitting on the bed. I don't want you to fall over onto the floor. It does not have to be a perfect flop, as if you really had paralysis. I'm okay with you, intentionally lowering yourself here or intentionally plopping back onto the bed or back onto there. Do not injure yourself at any point.
One thing that you can do is in the patient role is you might not have words, but you could be like, right? Like we make noises like that. That's what our patients do when they are feeling like they're going to fall over and they are phasic. They will make noises that you're going to feel nutty doing it, but the students will get the message that you are unsafe, that you feel out of balance. So don't be afraid to use strange noises. Not words like, hey, can you stop? That really bothers me. But that like, oh my goodness, like that kind of stuff.
It's a great chimpanzee.
You're welcome. Practiced on the way here. But those are the noises that your patients make when they are trying to get they're uncomfortable and they're trying to make you stop. So.
And then again, facial expressions, if you feel uncomfortable or you would think you would feel uncomfortable in that situation, any vocalizations, facial expressions, hesitancy, again, any of those natural responses you would have anyway are appropriate.
Yeah, you might be mad. Would you say grumpy? Your natural tendency? You could be mad and grumpy.
Cranky.
That's
Cranky.
Cranky, grumpy, grouchy, whatever you want, you know.
Whatever you...
So I'm curious, the movement to the chair, is that what brings on the thrombosis?
No, it's just you're just at a higher, yeah, you're at a higher risk after, you're at a higher risk. They have you on a prophylactic, but it's just a higher risk of, given that you had like
already.
Yep, it's just suddenly, you're suddenly getting that blockage with the pain. But it's an ischemic stroke from a block, so you would be at higher risk naturally of having, some sort of thrombosis.
And it doesn't go away.
It doesn't go away. In this case, we want them to attend, again, reality versus where our focus is. We don't want it to go away. We want them to attend to it is what our goal is. Are they paying attention to that red flag?
Do we still have vision problems?
You do. No, I'm sorry. So you don't still have vision problems.
Okay,
that cleared up. Correct. Good question. Other questions?
In reality, would it be warm?
Mm-hmm.
No, we can't generate that. Right?
Yeah, in reality it would be warm. I know, we were trying to figure out
But then it goes away.
But then it goes away, and we thought about that, and because we don't want them to palpate it in the first part of the scenario, we are not going to do the warmth. But yeah, the reality it would be warm. It's just a little hard to fake in the middle of this hypothetical case. Does Quentin want to grab them?
Quentin, whenever you're ready.
This isn't like a karate. All right, so we're gonna run through the case each individual, kind of just
Okay.
have Megan walk you through, just basically reenacting what we just went through. So you go from supine, sitting up, get you in the chair, get you back. We're gonna run the telemetry, so you'll get used to hearing that noise. And after that, if you have any questions, concerns, anything like that, let us know. We'll make sure we get those worked out before you leave. All right?
All right. Anybody?
I'll go first.
All right. Excellent. Move this out. We'll keep it kind of simple.
So I'm laying
So you're
down.
going to be laying down here to begin with. I'm not going to go through all the possibilities, but enough for you to just kind of get practice. So let's start on your left side because it's good. So if I asked you, can you lift this arm up?
Are we flat or is the head of the bed?
So you probably, it kind of starting, flat, usually comfortable that flat, but not totally flat.
Good.
I probably, most people don't like to be fully flat, but we're not going to be sitting up. But, as long as you're comfortable, and even when you get yourself set up, before they walk in, it doesn't matter if you guys are exactly at the same, I don't want you sitting up at 90, but most people are not comfortable at 0 degrees flat. So just make sure you're kind of laying down in a comfortable position. Just like
aspiration. I think so. They want to make sure that we don't choke or.
Yeah, so that's really what we don't want them to do is give you water. Like they're on thickened liquids, so they should not offer you water. If you said you wanted a drink, I would hope they wouldn't. We don't really have it in it, but that's really for them to think about in the moment. We did not add that in as you asking them for a drink to confuse them or anything, but within the case, we want them to know that. So that they should be prepping ahead of time, like, oh, what if my patient asks for a glass of water? They can't have it. But laying flat, we're not worrying about aspiration risk in terms of swallowing your saliva or reflux or anything at this point. You just, if you were eating, you have to thicken liquids. What's that? More probably like an applesauce consistency. So they would, and they thick it, if you had water, they would actually put it in and make your water thicker.
Or if you had juice, they would thicken it.
Thicken out.
Feel like honey thick. It's pretty gross, actually.
probably more of a yogurty type of, like, you know, but honey I think is a really good way of thinking of it, but it couldn't be liquid. And we put that in there specifically because there are often during PT, your patient will ask for water, and they need to be able to tell, you know, they need to be able to tell us at the debrief, like what, you know, those kind of things. Do they pay attention to that? But we didn't build it into the scenario.
Do we know that we're not supposed to have regular liquids, only liquids? So they said have some water.
Water, you could know, if they tell you, if they were to give you some water, which I would hope none of them would, absolutely go ahead and sip it and cough. So then if they came over to the right side and asked you to lift this arm, again with the arm itself, you're going to go ahead and attempt to lift it, within about that height, and just kind of let it flop down. If I was asking you to move your fingers, you're going to try, but really not get much. Right, so you could, I don't know if you guys can see over here, I could feel that he was, you know, something was contracting in his arms, but his fingers, other than his knuckle kind of moving, they weren't coming off the mat table at all. If I went to go move it though, he would let me bend his arm, let me lift his arm up this way. Same thing, if I moved his fingers, I'm going to be able to move the fingers. We went kind of more with that low tone, you can't, as opposed to, you know, holding back because it's really hard to act. Okay, so then, you know, if we went through all of it on the right and left side, again, you were able to lift your leg, you can go ahead and lift it a little bit, and oftentimes we're going to like naturally bend it, so you can kind of lift it and bend it almost like a heel slide, and then just kind of let it just flop back down. On this side, if I asked you to do it, you go ahead and lift that leg, you're going to lift it up, no problem. So, and we're really just looking for that contrast. So if they can see that natural strength on the other side, they're going to clearly know that this right side is very impaired. So, again, they could go either side. I'd expect them more to go towards the side that is stronger over on this side, because otherwise if they roll you to the other side, you're going to get stuck on that right side. So in this case, if I want you to come up, I could have this here just to protect you from rolling over. Some students may choose to keep it down and use their body to do that. But if I'm gonna ask you to roll over, can you roll over towards me? Again, you can move your head like you're gonna roll. You could try, but you can't move that side of the body. So I'm gonna move your legs so that we can move you over. So I might bend this knee up this way and hold it there. I'm gonna bring your arm across over here, and again you're gonna just let it flop. And then here I'm gonna take the shoulders and the hips and roll over. I want you to push up with this arm, and I'm gonna help you sit up. So I'm gonna take that from over here and under here, and then I'm gonna help him sit up. Okay. Oh, you just slide back. I want you on the edge there. So when we roll, and actually we will want them on the edge. If you feel uncomfortable, go ahead and slide back, but hopefully they'll be protecting you here. Now, if I were to let go because I'm trying to do something, this is where you're going to start to flop one way or the other, and he's right in the crack here. As I said, naturally, you tend to be in the crack. Most of us are used to standing in front and holding on, but there will be some of our students that are so worried about something else, they're going to do exactly that, and you're going to flop over. So you want them to have one arm over, or one hand on. Now they may, if they're working as a team, and we would love them to do that, put a second person behind him, or you, and then you'll be nice and secure. I forgot to bring a gait belt up, but we do have a belt that they'll sometimes use. It's usually like a plastic or a mesh belt that clips around you that they may use because you have a hospital gown on. I don't have it today, so we're going to do it without it. And in this case, I'm going to move him because I already know it's really hard for him to stand. So I'm going to keep him here, move his feet. All right, we're going to move from the bed over to the wheelchair. I'm going to help you do most of the work. So we're going to rock on 3. You okay? Okay. We're going to rock on 3, and I'm going to lift you, and we're going to sit right over here. Okay? You can reach with this hand over to here. 1, 2, 3. And that was perfect. Perfect. Already.
Too soon for the TV?
No, I think that's great. What I mean,
Wait a little bit?
I might make it like a minute or so because
Okay.
they may want to check to make sure you're okay. They may put the armrest on. It's really when you start to see that switch. So after like, okay, are you ready to go? Would you like to? You're my partner today. Okay, I'm done. Are you ready to switch?
Oh, the second.
To the second person because we're really looking for that switch. So make sure they've switched to the second person, and then
The second person doesn't do the lifting?
the second person is going to take them from the chair back to the bed.
Oh, that's right, that's right.
Again, if you're really wobbly, they may get a little worried that they can't do it by themselves. So 2 of them may be helping you over to the chair, but the one person will always be in the lead. Whoever started with you while you were in the bed should be in the lead. Then they're going to switch who that lead is. So there may have been, like during that, you may have a second, while I was in front there, they may decide they want a second person here who's helping him go over. Again, not, maybe sitting balance, I think less likely but that they'll do that, but it's not impossible that they would decide, oh, I'm really nervous, I want someone else standing behind that person. So then it would be to switch, and then whoever comes in front say, okay, we're going to get, from the bed over to the chair. So as soon as you start seeing that switch, you can start being uncomfortable. As soon as I come over to start transferring you, then you want that pain to get more exacerbated at that point in time. And then I might, say, is there something wrong? What's bothering you? Your leg. Up here? Down here? Down here?
Yeah.
And then if you push here, this is where you want to really get.
And behind the knee.
Behind the knee, anywhere in the back. So anywhere along the calf, behind the knee itself. So pretty much from that crease behind your knee, anywhere in that calf, is where you want to really, and then so again, if I go back and say,
Ow.
yeah, and you can do that, ow, it can be just, ah, it can be
Okay.
any sort of but
Okay.
it hurts.
So when you were transitioning him to the chair, and you said it's okay for him to use his left arm?
Yeah.
So it's mobile enough to...
Left arm is fine, you're totally
So
strong.
strong enough to...
Yep, we have no problems with your left side. You're like a weightlifter on your left.
Okay.
That's what I'm grabbing.
So yeah, you can reach out. It's just more, so what happens is that, they don't usually grab them to pull. What you do is you're going to put your hand out to slow yourself down. I'm going to use my right because I'm just for here, but if I were to sit and I had something there, I'm going to put that hand down there and your instinct is to slow yourself down. So when we say you can go ahead and reach with your left hand, you can put that left hand there. Again, you're not really, you're not pulling or anything, but, and it might, if you're a smaller person, depending on where you're standing, you have nice long arms. So, his arm might reach over and actually be able to slow himself down. If you're a tinier person in that distance, you're going to reach, but until you start sitting, that arm's not going to touch that handrail until you start to sit. And then again, your instinct is to protect yourself with the side that's intact, the side that doesn't have any problems.
And the movements when there's pain, should they be just your natural movements or should they be slower? When you're saying no or shaking your head.
Oh, they can be a little bit slower.
Yeah,
a little bit slower, but not dramatic. enough that you can respond. You don't want to be, it shouldn't be like super exaggerated or but if they, in terms of, are you okay? And you can, kind of a slow shake or a slow up.
Should you be more agitated or should you still be slower?
You can be more agitated again, the pain is, it can be much more agitated once you're over here. If you're answering those questions, again, much more agitated, much more, probably less of a a quick gesture to the leg, like you had done was fine. Much harder to answer long questions, just much more vocalization and discomfort.
Okay.
Questions?
How's the pain?
Still there because he hasn't gotten back in bed.
Does
But-
the pain go away when you get back in bed?
No, it'll still be there. I mean, but you don't have to be screaming at that point. Once they get you back in bed, that will end the sim. But if they are hanging around for a minute or two, it's still there. You're just not screaming because you're not weight bearing on it. You're not touching it. And they may, and again, if they suspect it's a DVT, the protocol would be to get hold of the medical team to determine whether they even want you in the bed. And if they do, they really should be doing like a dependent transfer over rather than you weight bearing on that leg.
The second person probably should call for it.
Yeah, they might stay with you and ask their partner to call, but somebody should be calling during the second one. So they may actually not do the transfer necessarily on the way back if they actually call and we end it. And then if they call soon, then we will want them to kind of explain what they think is going on and talk out loud. Their area of expertise should be musculoskeletal system, so we certainly don't want them calling saying they have leg pain without them having assessed what they think the leg pain is a possibility from.
What about post-encounter? Is there a checklist then?
So you guys do not. So you guys have a really, it's pretty easy.
Personal feedback?
We do a group debrief. At this point, we have not with the group in acute care have had the SPs fill out anything. But we will they'll do their pre-brief, come in and immediately go to their debrief with the
So
faculty.
no feedback at all?
So no feedback right now.
I think
We
it's
may
just a
change it.
checklist.
What's that? Yeah, we may in the future add it. This is a follow-up to the one they do in the spring. At this point, they are just still really at a point where Lions Tubes monitors, stuff all of a sudden goes out the window when they've been doing these transfers for a year and a half. The one was a year and a half ago, they've been doing these transfers, but in outpatient settings. So before they get ready in the fall to go out on their first inpatient, what we are really trying to get them to look at is the bigger environment. So our hope is after the one in the spring and the feedback they got in the spring, that they take in the whole environment, how the person reacts, what the monitors are saying, as opposed to, we'd love to get to the point where we could get some feedback about what your interactions are, but they are still at a point where they're a little overwhelmed for that.
How long was the interaction?
So it's 20 minutes total. They have 10 minutes. They're given the guides that you have 10 minutes to get the person out of the chair, 10 minutes to get them into the chair. I mean, the transfer itself does not take very long. That's why I said the first person, though, they may be more hesitant when their patient can't move in the bed a lot. So it may take longer than 10 minutes. That's okay. As long as they're almost on their way over, because we know that second part does not take a full 10 minutes. Anyone else want to try? Make sure that you're okay with the motor skills. Are you good? Do you have questions?
No.
Oh, excellent. Thank you.
I'd like to 4 o'clock.
Sure.
It's been a while.
Is there a part that you feel is more difficult? The laying down, the transfer part?
I don't think so.
Okay.
I'll be right back.
Sure. Can I take my shoes off?
Just to be clear, that they won't be asking us to walk.
No walking. No, we're not going to do that. That would be a more advanced skill that we just, given the time limits, don't have.
Or if I'm a sweater on, it doesn't matter.
No, it doesn't matter. I mean, you guys will have the gown on for the day of, but for this purposes, for practice. So again, so if I'm over on the left side and I ask you to lift this arm up, no problem. Can you bring it down here? Can you hold it right there? Don't let me push it down. Again, push up as hard as you can so you can see.
Ooh, strong.
You can see, again, your natural resistance, because what's going to happen is, I'm going to skip the legs just for comparison. When I go to ask, can you lift this arm up here? You get it up, but then you're going to drop it before I even touch it.
Okay.
Or if I'm quicker than you are, as soon as you feel me touch it, so go ahead and lift again. And as soon as I touch, you want to drop it down. So again, even if you feel like they're strong and kind of can break that on that left, your natural strength on your left, you want to make sure your right is much weaker than the left side. So then the same thing with the legs. So if I ask you to bring your knee up towards your chest, great. And then if I ask you to hold it there, nice and strong, you can go ahead and put that down. And they may actually tell you to bring your knee up. So if you lift it your leg that way, they may say just, can you do this and bring your knee up. just because in the bed it's usually a little more comfortable. Some people can't raise their leg up that way. Can you do the same on this leg? And again, as soon as I'm touching it, even less than that, you could give on that leg. So as soon as you bring it up, just go ahead and bring it back down again. Again, they can see you can move it, but you really can't take it.
I'll wait for you to do the resistance.
Well, as soon as you feel my fingers, don't, because they may be pretty fast. Sometimes, like, our brains, because you're taking, as soon as you see me going to get ready to touch, you go ahead and drop your foot. More because our natural instinct when someone touches there is going to be to resist, so it may feel like you're resisting before you actually can. So as soon as you see them to go to touch, go ahead and let that leg drop down. We want them to be able to see that you moved it, but we don't want them to feel any resistance. We're going to do this side just to give a different example right now. For a second, I'm not going to bring the chair over yet. But if I did roll you to this side, right, this side you'd be able to help. So if we noticed on the other side, you couldn't reach over. I would hope they don't roll you on here because they're going to trap your hemiparetic arm under you. But they could. They may decide the lines are over here and we want you to go over here. And so they may say, okay, we're going to roll over to this side. So you can reach over, you can bring this knee up, and you can push and go ahead and roll yourself over. And it's going to be, you can see I didn't nearly need to do the amount of work then when I went to the other side. But now it's going to be much harder for me to get her up because she can't help at all. So at this point, I'm going to have to try to get way under here. With the guardrail, it's going to be much more difficult. So you're going to have to roll back, and you're not going to be able to help. So they're going to have to either put the rail down or try to finagle under there, and then really dependently lift you up.
What if they decide, like, oh, let me just flip you the other way?
So that like this. So then say, oh, yep. So then you can roll back just fine because gravity is going to take you down. And then we're going to be back in the scenario we started with over here where, okay, we're going to roll towards this side, and you really can't help on that side. So I'm going to have to bend this knee. Again, I'm going to bend it here. If I walk away, it's just going to flop down. So if I bend it, I want to hold it there. And then I'm going to take this arm, and we're going to move it right across your body over here. Excellent. And then on the count of 3, we're going to roll you over. 1, 2, 3. And again, this arm, the instinct was good. Just grab the rail because you can use that hand. The top part is really floppy. You can't do much with it. And then from here is where I'm going to ask her to, I'm going to have you push up through your elbow here. I'm going to come right underneath of you, and then I'm going to get your legs, and we're going to sit up. There you go. And great job. Nice floppy arm on that side. Questions on that? Very nice job.
Thank you.
Did you want to practice going to the chair? Or
no, we're not. Gone this far so far.
Right. So we're going to scoot you a little bit to the bottom, a little to the edge here. Get your feet to touch. Excellent. All right, then I'm going to have you lean towards me. I'm going to count to 3, and we're going to spin over to sit in this chair. 1, 2, 3, and over. And I didn't ask her to reach, she naturally reached. Now you can see I may want to reposition her here so I'm still the first person. And I may have you lean forward this way. Then we're going to scoot you back a little bit.
Do I help you with that?
You can help with the left side only.
Okay, a little bit. Okay. Good start.
No, you're fine. You're good.
I have to remember not to scratch my face.
All right, good. I'm going to give you your shoes. Excellent. Something bothering you? What? Something hurt? Your leg? Right here? Up here hurts? Here.
Ouch. Ouch.
Perfect. And again, ouch is fine. If you really push right on between back and the knee, I would just yell.
Yeah. Okay.
Like just, ah! Yeah.
Okay. Ah!
anything that, like, think about, like, if you, and mostly your natural response too. Like, if you've ever done anything where, you hurt yourself or usually there's some sort of, like, just vocal yell as opposed to a word attached to it, like, hopefully not, someone was making our speech. But you don't have the speech language, so some sort of vocalization that is really indicating some sort of pain. All right, very good, thank you.
Thank you.
Anyone else? Or part of it, what part do you think might be the most difficult for you? And she walks out.
Remembering not to talk.
Remembering not to talk, yeah.
So yes or no? Yeah.
Yeah, yes or yeah, yes, no, and gestures. And that's easier than in between. We picked that intentionally because it's a little bit easier to go to that extreme than to give you something in between, because then if you have some modified speech, it makes it more hard.
We can't get any words out at all?
Again, your name, hospital. If you get a single word out here or there, that's fine.
Okay.
I'm not overly worried, about that. But, to get any sort of comprehensive sentence out.
Right.
For simplicity, we just
It's
said, not speaking in gestures, but the reality would be single words, oftentimes the wrong word. So you might be trying to say, someone's name and you say the other person's name, or you're trying to say leg and you keep saying door. So oftentimes, like, even when you hear it, it's the wrong word. But we do want you in the beginning to say your name and hospital so that they know that, and put just single word. So whatever your name is going to be, first name, not your full name, first name and hospital. If they ask you which hospital, you're just not going to be able to get it out.
And date of birth, tell them.
Yeah, no,
No,
the date of birth.
not.
Just, you can yes, no, the date of birth, if they look at your band and they say, you can agree that whatever was on your band is accurate, but not actually state the words. Yeah, thumbs up or yes is fine.
When we're on a med-surg floor, we're not still in the ER?
You're on the stroke unit.
We got admitted.
You're admitted. You've been here a day. You're on the stroke unit, and this particular hospital has a stroke unit. That's what so they know that's the unit that you're on.
Any idea how many students are going to be?
I do think I would say this, right? It's 8, I think. I was just doing schedules, and I'm trying to make sure I have the right cohort. That should be that's about right.
So you should sound slower, but normal. Or
Yeah.
should you sound like, my mother had a stroke and she
If
did
you
not,
can, it's right. You can, again,
not sound normal at all.
and it depends on what's affected, right? So oral motor skills, you can have a stroke where it affects the muscles and in your cheeks and your tongue, and so it's going to come out, but you just can't form the words, and that's going to be much more of a slurred speech.
Okay.
Or you can have a phase of, which this is what this patient has, where their brain is telling them what to say, but the words that come out of their mouth don't match up or they can't get them out.
Can you give an example?
So that's what I was saying. I said, like, you might want to say, what hurts, and, you theoretically, you're trying to say leg, and you keep saying door.
Oh.
And then you get really mad because you're like, no. And then you're like, door, and no. And then sometimes it'll come out, sometimes it won't come out. And the reality, you often get more than one word out, but it becomes, because there's some subtlety, and if you haven't, it's really hard to act and stay in the moment and get all of those skills down. So we try to make it much more simpler with really sticking to the yes, no, and the gestures. It makes the student have to really attend to the person and their reactions, as opposed to not looking at them and just listening to their words.
Yeah, when I was doing the demo, it felt real to me when you kept narrowing it down to like where the pain was.
Okay.
Yeah.
Yeah, and so and we want them to attend to that aspect of, okay, I need to communicate with this person differently than I would, someone who could verbally answer all my questions.
Does it matter whether it's ischemic or hemorrhagic? The way people...
Well, it does. I mean, depending on the location, usually if you have a hemorrhagic, depends on how large it is, but it's going to hit more areas versus if it's very isolated. And so the common presentations differ. Now, theoretically, it could be similar based on the percent, like the location in the brain, the percent of the hemorrhagic stroke versus the ischemic stroke, how long, before it cleared up, etc. So this presentation is more common with an ischemic stroke in the particular MCA artery on that left side. So this is just as a more common presentation. Again, people present differently. We just try to stick with something that would be aligned physiologically that we might see in the clinic.
So you think ischemics tend to recover more, or it depends on?
It depends. Depends on lots of things. It depends on both when they're caught. We do have some really, I don't perform it because I'm a physical therapist, I see them afterwards, but in some of our stroke centers, if they get in soon, there's some pretty amazing medical interventions that can be provided that, I just as a personal example, my uncle had a stroke, was medevac to Cooper, and based on the level of the stroke, he should not have walked out of that hospital, and he had minor aphasia that he recovered within a couple weeks of therapy. But he should have been in an inpatient rehab and left Cooper because they were able to get to him in time and actually provide medical intervention. So really, there's so much that differs, from person to person. So there are some individuals that if they get to them in time and they might not have as much hemiplegia. There's some that, depending on what their treatment is or before they recognize it, that's why we talk about it, when you recognize you're having a stroke, how long before you call 911, how long do you get into the hospital? The sooner you get there, the sooner you get the treatment, the sooner you get the recovery. But we try to pick something kind of the middle ground that would be very common to see.
I sometimes wear a double gown.
Okay.
I'm cold. Is that going to be too much? You don't care?
No, one in the back, one in the front.
Exactly.
Yep, that's fine.
Okay.
Yeah,
It's kind of more material, but we're going to be under a sheet anyway.
Yep, no, that's fine.
Thank you.
Exactly, I can ask them to make sure they have the double gowns
Right
available.
now, I'm standing.
It's warmer.
Okay.
Any other questions?
We have your address, so if.
Yep, absolutely. You can go ahead and email me. I'm happy to answer questions. If you get home or practicing and you're not sure what to do, and same thing, I'll be here early in the morning out so that if you have questions, we can go over it.
I take it that's going to be, is that locked?
The wheelchair should be locked.
Yes, so we don't feel.
Yeah, it should be locked.
Okay.
Again, your left hand works, so if you need to.
Right.
And then again, if you miraculously suddenly your right leg kicks in because it needs to, so that you don't fall. And I would say again, this is the second time they've done this with the SPs. They've all had lab practicals. We were the patients. We're pretty not nice as patients, so we've really leaned into them before that, so they've had to, I've buckled on pretty much every one of them at some point during a checkoff list. So I do expect that, it is a little bit more nerve-wracking. They haven't met you all before. There are two of them, so our hope is, again, we try to keep it kind of a psychologically safe environment as best as possible, so they can tag team. If the other one notices the wheelchair is not locked, someone will hold it, or they'll ask to make sure it's locked. Knock on wood, they did pretty well with that in our last SPL.
How many encounters do we have?
Let me ask, because I didn't write that down right now.
It's like, I think I did 5 in the morning, and then I think I did 10.
Yeah, that's what I was expecting.
Because it's like, what, 4 hours or 4 hours?
What day?
It's
Monday,
supposed to be at 7:30.
2 weeks.
Yeah, I think it's like, there were a few.
What time?
8:30.
2, 4,
It's about 10, right?
10, 12, 5. That should be right.
Oh, nice.
Yeah, you actually have lots of time on this one because we do the pre-brief, come in here, you have the 20 minutes, and then we do the debrief, followed by the next group's pre-brief. So you have plenty of time in between to use the restroom or, to do something in between. It's not back to back to back to back, kind of like when we do our outpatient ones.
Cool.
So there's ample time in between the 5 groups.
Just 5?
Yeah.
That's it?
Yeah, I was just counting.
For the whole day?
Yes. Other questions?
I've heard of strokes where people who are bilingual lose a language. Have you
Yes.
seen that?
Excuse me, what did you say?
That if after a stroke that were bilingual, they lost one of their languages.
Ooh, can we speak
No
in
way.
tongues?
Every time I do these training, I get the most interesting questions. Not this time.
Oh, shoot. Interesting.
All right, any other
Human body
questions?
is mind-boggling, you know.
Great. Well, thank you.
Thanks, Megan.
Thank
All
you.
right, so
Thank you.
I can't get out of my armchair. Let's talk.
Well, I'm here, I mean, it just really depends on what's going on, you know.
You're doing
I'm
that.
gonna see if I can figure out that one last time. It was fun, it was a big conversation.
Yes.
Take care of the cat.
It'll be fun. Yeah, thank you. No. All right, then. I probably said, I just thought I had some tape that he could pick up.
I'll leave these in your good hands.
Anyway. On my way.
Thank you so much.
Thank you.
And she's happy. Yeah, I have one. All right, thank you. So they'd like to show us some little smileys.
They may ask, I mean, we have them printed out, they take them in, they may show you a picture version of it, or they may ask you on the ear to 10.
Okay.
Last minute notes or anything we need to touch on?
Do you have questions for me?
Nothing.
The only thing that they had asked is about double gowns. I'm fine with that if you, so they can put one on in front and
I
one
was
on
wondering
back.
what that question was.
Yeah.
Just curious.
And I'm fine. In fact, I usually, I would say most of us, if we're getting a patient up, I go get a second gown to put on. So they can just be, when they're in bed, they can just have the double gown, one behind, one in front.
I think that mostly it. Yeah, because our last.
Are you back for 12:30?
I am not leading that one, but I am here to help them with some of the, Heather always gets, she's like, I always get the timing mixed up, but I am not the cardiopulmonary person at all. I am actually peds. I never love the stuff that comes on in here, but I'm the one that does the same stuff. So, but content-wise, she'll be up here, but I will be back with her, for that one.
Yeah, I think we covered most of it. We'll figure out how we're going to get the catheter and all that
So, yeah,
stuff.
we have a whole drawer full of ACE wraps, so if you have
Oh, that's
something
what we
velcro-
do too.
Yeah, okay.
So we'll have
yeah, we
something.
should-
We just gotta workshop it. That's all.
Yeah, so I figure.
Yeah, I've done everything. I mean, I've had shorts on. I have the drawstring ties, and I've tied it to the drawstring before.
That's not a bad idea.
Because only because sometimes like it would keep sliding out of the ACE wrap or something. But I mean, yeah, I mean it doesn't matter. Just our purpose
Just
in that is
something
just
to
so that
keep it in place.
just so they have to pay attention. So when I'm moving the patient, I need to make sure that I have the catheter bag with me.
It's just in here.
Yeah, I got it. You have precious cards.
I know. Well, I had my few minutes already. What about the packaging?
Question?
Yes, so you sent me an email about, and I'm sure this is, yes.